All right, so today we're going to go through the knee unit notes, starting with the bony anatomy. As you can see in the picture here, you have the femur, which is the thigh bone, the tibia, which is the shin bone, and then the fibula, which is the non-weight bearing lower leg bone. You can see also that you have 4 ligaments in and around the knee. 2 of them are inside the knee, called the ACL and the PCL, and then you have the MCL and the LCL on the outside. We'll get to those in the soft tissue section, so we're not going to worry about those right now. And then you have the patella. As you can see, the patella protects the front of the knee. So in looking at our notes, I've done a side-by-side so you can see the actual guided notes section that you will fill in, and then the PowerPoint is over here. So first off, the knee joint is the largest joint space in the body. The knee joint is greatest in its spacing at 30 degrees of flexion. So 30 degrees of flexion is the knee slightly bent. All right. The knee is also a synovial joint because it has a joint capsule. And we need to know what the synovial fluid does. Synovial fluid is like oil in a car. Know that when you have a car and you don't have oil in it, it clicks and clacks, and sometimes it breaks down. Same with the body. As the body ages, naturally we lose that synovial fluid. So that's why as we get older, or as we put more weight onto the joints, they start to click and clack or pop, and they swell, and they start to hurt. And that's because that synovial fluid is not lubricating the joint and keeping the movement smooth like it should be. So what is the purpose of the synovial fluid? The purpose is for lubrication and for nutrition. Right? So the synovial fluid brings nutrients to the joint to help it with repair or with growth, but it also lubricates it. All right, moving on out of that first section. So if we look at another view, you can see the pinkish area. This is called cartilage, right? But inside that cartilage is the synovium. Here's a better view from the side angle of the knee. So this would actually be a medial view because what you see here is the tibia, and then on the back side you see the small fibula. So a medial view is showing the majority of the tibia. All right, so the synovium in this picture is the green-like fluid. All right, so as we age, or as we do squats, or as we play sports, this starts to disappear. And when this disappears fully, like it is over here in this picture, you're left with cartilage rubbing on cartilage. This is called articular cartilage. Okay, articular means it's on the articular surface or the moving surface. So it's on the femur and on the tibia. So when those things are removed, you then have bone on bone. Bone on bone creates a lot of friction. That friction creates inflammation. That inflammation is called arthritis. All right, so moving into our notes, more into the bone section. Here's an x-ray. You can see the femur, the tibia, the fibula, and then the little old patella. So the femur is the largest bone in the body. It is actually the strongest bone in the body too. It's very hard to break your femur because it is completely covered by muscle. The only part that is not covered by muscle is when you bend the knee and expose the underneath surface of the medial and lateral condyles. So the distal end, remember distal means distance, so the distal end of the femur makes up the knee. The proximal end makes up the hip, which we'll learn more about in our next unit. So if we look at a femur, all right, here's the knee, here's the hip. Distal, proximal, all right? So we're just going to concentrate on this lower section here. So when we look at a femur, We sometimes might think, well, how do I know if I'm looking at it anteriorly or posteriorly? Anterior means front, posterior means back. The way we know is by this little notch right here in the center. This is called the intercondylar fossa. This is important because this is where the ACL and the PCL will track. Okay. Sometimes in surgery, they'll have to go in and shave that out a little bit if there's a small area. So when we're looking, we look, okay, we see this, and then we think, okay, if I'm standing in this direction with that part of the knee facing me, then this must be the right femur. And as you can see, it says right femur at the top. So yes, we are correct. Again, just another view of the knee. So we have what's called the screw home mechanism. The screw home mechanism is when we extend the leg completely. When we extend the leg, the tibia rotates externally, which means it rotates out. And this is because the medial condyle of the femur is larger than the lateral condyle. And then you have the trochlear groove, which is where the patella glides. So if we go back and look right here, this little indention is the trochlear groove. Okay. Moving on to the tibia. The tibia is the lower leg bone. All right. Two tuberosities to the tibia. They are concave in nature. The importance of the tibia in relation to the knee is where the ACL and the PCL attach. Then we're going to see if we can get this video to play. So if we look, he's going to get the ball up here. So as you can see, he steps and he's getting ready to go in, but the guy in blue is going to come from the back of his tibia and make just a perfect hit and break the leg. And you can see as he gets ready to fall that we have an open fracture of the shaft of the tibia. So most tibial fractures, when they happen, they're not very pretty. They cause a lot of pain and typically have to result in surgery. Sesay's fracture was right here in the middle of the tibia. Okay, ankle down here, knee up here. So moving into the patella. The patella is a sesamoid bone. Sesamoid bones are what's called free-floating bones. This is the largest one within the body, and it lies within the quad tendon to increase function of the quadricep and patella tendon. So the main function is to protect the anterior knee, but also to increase mechanical advantage, which means it's going to help us in jumping and bending. Okay, you see that it sits within the quad tendon. The quad tendon wraps around the edges and comes right down here to the patella tendon. So you see it gives it a little extra force. It's most palpable in extension. So when your leg is completely straight, put your fingers on both sides of your kneecap and you can move your kneecap around. Try that with the knee bent. I bet it's a lot harder. So 2 injuries that you should have done in your injuries and illness section. Patella baja means low riding patella. As you see right here, this patella is hitting into the fat pad, which causes irritation and tendonitis. Patella alta, as you can see here, this patella is high riding, meaning that it should sit right here, but it is sitting way too high, prone to more dislocations. So why do patella dislocations happen laterally? Well, you have a 3-to-1 ratio. First off, when you think of the quadricep muscle, quad means 4. So you have 4 parts to the quadricep. 3 of those pull towards the outside. The only one pulling towards the inside is the VMO. The VMO is vastus medialis oblique. It is a very small muscle on the front of the knee, which helps to stabilize the patella. Okay. Other reasons why trochlear groove is small or shallow. The patellas are abnormally shaped or they are small. Q angle is increased. The IT band is tight, which is on the outside of the leg, or the retinaculum is tight. But the most common reasons are these first two, weak VMO and shallow trochlear groove. So you can see here in the x-ray, here's the patella, here's the trochlear groove. So this is what it looks like on a body. So this is a leg, and then this is the patella dislocated. The way it's put back into place is you put your hand on the side of it and you slide it back over. Chondromalacia patella is another issue with the knee. Chondromalacia patella happens from a lot of overuse. So it's where the underneath surface right here becomes very frayed. What it does is it causes inflammation and popping and clicking, and sometimes the kneecap will catch. And we'll stop right there for the bone section, and I'll continue on tomorrow with the ligaments.